Okay, it's about 12:02, so let's just jump right in. Thank you everyone for joining us today for our community conversations on cancer, lung cancer screening addressing a population health priority. Our community conversations on cancer series is presented by Wilmot Cancer Institute's Office for Community Outreach, Engagement, and Disparities in collaboration with our Community Cancer Action Council, or CCAC. The CCAC is made up of individuals and organizations from across 27 counties in upstate New York, all working with communities today to lessen the impact of cancer tomorrow. This event has been designated for 1 AMA PRA Category 1 credit and 1 contact hour for social workers by the University of Rochester School of Medicine and Dentistry, accredited by the Accreditation Council for Continuing Medical Education. At the end of this event today, participants will be able to define the inclusion criteria for lung cancer screening eligibility, appreciate the impact of screening participation to patient outcomes and population health, and describe the local resources available to assist in lung screening and smoking cessation. No financial relationships have been disclosed by our presenter or our planners for today's event. Throughout the presentation today, please feel free to type any questions that you have in the Q&A box located at the bottom of your screen. A facilitated Q&A session will follow this presentation. So without further ado, let's get started. I am very excited to introduce our presenter today, Dr. Ben Wandtke. Dr. Wandtke is the Vice Chair of Quality and Safety and the Director of the CT Lung Screening Program at U of R's Department of Imaging Sciences. He serves as Chief of Diagnostic Imaging at FF Thompson Hospital, where he practices as a general radiologist. His funded research focuses on health system quality improvement, most notably, the development of the Backstop Radiology Recommendation Tracking System that assures patients with incidental findings receive appropriate follow-up care, eliminating delays in the diagnosis of cancer. Dr. Wandtke is active in radiology and systems leadership, currently serving as the president of the medical staff of FF Thompson Hospital. He serves on the board of the FF Thompson Health System and chairs the FF Thompson Population Health Committee. So please join me in welcoming Dr. Wandtke.
Thank you, Christina. Appreciate the introduction. And thank you everyone for joining us this afternoon. So we'll be talking today about CT lung cancer screening, what I consider a population health priority. We'll go through these slides. So the objectives, as we discussed, were to define the inclusion criteria for lung screening eligibility, appreciate the impact of screening participation on patient outcomes and population health, and to describe our resources at the University of Rochester to assist in lung screening and smoking cessation. So for me, a discussion about population health starts with the discussion of mortality. And it was very clear to me for a long time that the number one cause of mortality in the state and nationwide is heart disease. I've always thought of that as the largest issue in population health, is addressing heart disease. But when you stop and think about premature death or death less than the age of 75 in the state, the incidence of cancer now outweighs the incidence of heart disease by a fairly significant margin. And other causes such as cardiovascular disease and stroke are much lower on the list. So focusing in a little bit on cancer, looking at both men and women, lung cancer is by far the most common cause of mortality related to cancer, above other common cancer types such as prostate cancer, breast cancer, colon cancer, where we have very robust screening programs. Looking at the impact of lung cancer stage of diagnosis. So there's early stage diagnoses, which are very localized to the lung, small masses in the lung, and there are middle stage diseases, which are in the pink box here. Those have spread to the lymph nodes within the chest, but not outside of the chest. In the green box is the metastatic cancers, which have spread more widely. So about half of all lung cancers are diagnosed at a widely metastatic stage where treatment options are very limited. Another quarter of lung cancers have already spread into the lymph nodes in the chest, where a simple resection would not be adequate to contain the cancer. And about 1/4 of cancers are identified at an early stage where surgical resection is a very viable option, which actually gives our best outcomes. So you see here the 5-year survival for early cancers is very high. It's about 60%. It's much higher than any other stage. We still do fairly well with some of the regional spread into the lymph nodes with our chemotherapy and radiation therapy treatments, but our treatment of distant metastatic cancer is very poor at 6% or even less for some cases. And unfortunately, those were about 50% of our diagnosis of lung cancer. So we've got commonly diagnosed advanced stage cancers that are very hard to treat, and we have rarely diagnosed early stage cancers, which we have very good outcomes for treating. So as a radiologist, I'm very familiar with seeing these types of patients. This is how we usually diagnose lung cancer. Often a patient has come into the emergency department for chest pain, or maybe signs of infection, like a pneumonia, and they get an X-ray. We find a mass, they end up doing a CT scan, and we see large masses on the order of 3, 4, 5 centimeters, often with other masses in the lungs, and sometimes spread to the liver, to the bones, and lymph nodes well beyond the chest. Fairly rarely do we see incidentally identified smaller lung nodules that are of large enough size where we know that those are concerning for cancer, which would warrant a biopsy or more urgent follow-up, like a PET CT scan, where we can diagnose early stage lung cancer. And this is a type that's about 1 centimeter to 1.5 centimeters, smaller than a golf ball, and something that could easily be resected by a surgeon and leaving a lot of the lung tissue in that patient, and gives us very good survival rates of about 60%. So when we start talking about, again, going back to population health, when we talk about modifiable behaviors that lead to mortality, is probably the next most important thing that I like to address when I think about population health. So tobacco and poor diet and obesity are the two largest, but you'll see that tobacco is the #1 modifiable behavior that leads to poor outcomes. Now, it leads to outcomes in cancer, with lung cancer. It also leads to poor outcomes in heart disease and stroke. But as a modifiable behavior, it is the #1 target we should be addressing for population health. When you break down the data for the state of the percentage of adults who smoke cigarettes by county, you'll see that the lowest rates are in the city of New York and its surrounding areas, where almost every county is at or below the 15% average. This is some older data, 2014. I think our rates have dropped by about 3% since then across the state. But as we go to Monroe County, our rate is about average for the state, but we have a lot of surrounding counties where the rates are significantly higher. And that's one area where we're trying to address the disparities of health with high smoking rates in our surrounding counties in upstate New York. When you look at the age-adjusted lung cancer mortality rates by county, you'll see that the counties that are around Greater Rochester area in upstate New York tend to have the highest rates of lung cancer, probably aligned very well with the rates of tobacco use. And as I blow up on the area of our surrounding counties, every one of our counties, including Monroe County, has a higher than average rate of lung cancer mortality. So if we turn back the clock to 2010, we have, and think about lung cancer, we have a condition which was very common. It was the most common cause of cancer mortality. It has high mortality. It is the majority are presented with late stage disease for which we have few treatment options. There are much better treatment options and outcomes for early stage disease, and a disease incidence that is strongly linked to a modifiable behavior, yet we had no proven screening tool. And unfortunately, in 2011, there had been research ongoing that started in 2002. In 2011, we had the biggest article about lung screening. The National Lung Screening Trial came out in the New England Journal of Medicine, and it showed that everyone participating in lung cancer screening had a relative reduction in lung cancer mortality of 20%. So that kind of shocked people. That's a pretty big number. And they also had reduced mortality of all causes of 6.7%, which again was unexpected and higher than anyone had anticipated. That research led to the United States Preventative Services Task Force to create a recommendation, a grade B recommendation for lung cancer screening for patients aged 55 to 80 with a 30-pack year history who have quit smoking within the past 15 years. And so just to fast forward through the timeline a little bit, after 2013 and that recommendation came out, the American College of Radiology looked at the data, and one of the concerns was there was a relatively high rate of false positive tests with the screening tool. So they parsed through the data and they created what's called lung RADs, which is a standardized way to interpret lung screening examinations that led to a 50% reduction in false positive rates from the initial screening trial, while maintaining the sensitivity of the test or the ability to detect early stage cancers. And based upon that work and the US PSTF recommendation, the Center for Medicare Services adopted payment for lung cancer screening in 2015. There have been some subsequent trials, the MILD trial, the Nelson trial, which supported the overall mortality reductions and the relative risk reduction for lung cancer, as well as upgrades to the ACR lung RADS criteria, further reducing the rate of false positive screening tests. And ultimately in 2021, I'll talk a little bit about the updated recommendation criteria from the US Preventative Services Task Force. So now we have a tool that is called the annual CT lung cancer screening based upon the National Lung Screening Trial that is essentially free to patients. And I'll explain, there's a couple caveats, with no cost or co-payment. That is a quick test. It takes about 5 minutes or less on the CAT scanner. There's no IV being placed. It's pain-free. It's a very standardized test. We have very rigorous criteria about how much radiation you can expose the patient to, and how these tests are performed and interpreted. And it's been shown to be very effective in multiple trials for reducing the rate of lung cancer mortality. Here's just an example of the criteria that a radiologist used to interpret the study. Now, this is beyond the scope of this study, but there are very compartmentalized approach to this, where we get a standardized interpretation. And all of the radiologist interpretations are entered into a registry, which is stored for research purposes and to prove that in practice, lung cancer screening is having the same or equivalent benefits as we are seeing in the initial trials. One of the differences with lung cancer screening versus screening for colon cancer and breast cancer is that this is a risk stratified screening population. That means that not every patient of a certain age meets the inclusion criteria. So you have to have a certain tobacco history, which increases the chances of finding cancer. These are higher risk patients, and decreases the false positive rate. But at the same point, so it's a more effective screening tool and it's more cost effective, but at the same point, it led to different challenges in patient identification. So our EMRs were not really aligned to identify these patients easily. It led to the discussion of shared decision-making. So we decided we don't want to have patients receiving annual screening if they're not eligible or willing to follow through with a positive result and undergo treatment, which is, a very rational approach, but at the same point requires some additional documentation and effort and complexity to the program that doesn't exist for other screening programs. There's a requirement for a registry, which requires labor on the side of screening programs, as well as IT resources to gather the data from your screening program and put them into a national registry for research purposes and for quality improvement purposes, as well as the concept of prior authorization and insurance coverage which has been an off and on battle for lung cancer screening compared to other screening modalities. So going back to our criteria for 2023, so these are the criteria that that CMS approves and all insurers pay for. So there's no charge to patient for who meet these criteria: ages 55 to 80 with a 30+ pack year smoking history. They have to be a current smoker or quit less than 15 years, and they have to be asymptomatic for lung cancer. So they couldn't have a large unexpected weight loss or been coughing up blood or having other signs or symptoms of lung cancer. And they should they need to be a candidate for treatment of lung cancer. All right. So based upon those 2013 criteria and the adoption, the slower adoption of payment by CMS in 2015, when you looked at how the nation was performing in identifying and screening this at-risk population for lung cancer, with this test, which has been proven to be effective at reducing lung cancer mortality, we were failing in 2018. So it was identified that about 5% of eligible patients in the entire country were being screened, and only 4% in the state of New York, which compares poorly against screening rates for more established cancers like colon cancer at 58% and breast cancer at 73% of eligible patients. So there's been a good bit of research about barriers to lung cancer screening, and there are many. There's the lack of awareness of the screening programs. There's perceived stigma around tobacco use. Patients have to self-disclose their tobacco history in order to be eligible. There are cost concerns, particularly in areas when the program is new or expanding, where some patients may have to pay out of pocket for what is essentially a preventative service. Access to imaging sites. So because of the registry component and the IT and labor required to participate in the registry, not all regional sites were able to easily adopt lung cancer screening. There's also issues at the provider level with the difficulty identifying eligible patients. I discussed that the EMRs were not able to easily create a pop-up that says this patient, is eligible and we should have a discussion at this visit for lung cancer screening. There's also unfamiliarity with the criteria. They're a little bit more complex than simple age-based criteria because they're risk stratified. And there's there's a requirement for documentation of a shared decision-making visit, which we'll go into a little bit more, but it's basically explaining the program to patients, the risks and benefits of the program, and assuring that the patient meets the inclusion criteria. That takes time, and that has to be documented and billed for proper compliance with the program. There's also insufficient time or training to address smoking cessation, which is a required element of lung cancer screening participation. And sometimes, and has been some skepticism about the benefits of screening early on. I think that is waning now. There are also issues around racial disparities in screening. The initial lung cancer screening trial had a population that was 91% Caucasian, and early data is showing that Blacks, Latinos, Asians, and Indigenous Americans are less likely to be diagnosed with early stage lung cancer. They are less likely to receive surgical treatment, and they're more likely to receive no treatment for a diagnosis of lung cancer. So in 2021, the lung cancer screening criteria were updated. And this was when they looked closer at the data and additional data that had been coming out from the Nelson trial and others. They realized that it would be cost effective to screen patients more broadly. So including the age, or reducing the early age from 55 down to 50 for eligible patients, and reducing the smoking history from 30 pack years down to 20 pack years. You still have the requirement to be a current smoker or quit less than 15 years from the screening date. This expansion in criteria added 6.5 million eligible patients in the US from a baseline of 8 million. So it went up by about 80%, the eligible screening population. But there was even larger increases in some of the minority populations as well as women. So this did address to some degree the racial disparities around lung cancer screening, although they've not been completely eliminated. All right, so going back to the chart where we were showing that we were struggling in 2018 reaching only 5% of the 8 million eligible patients by the 2013 U.S. Preventive Services Task Force recommendation criteria, we've now expanded that to 14.5 million Americans, or about 4% of the overall population of the United States who are qualified for lung screening. So that's really taking this number and cutting it in half. Fortunately, we've made some progress from 2018 to 2021, where the rates nationally are more like 9% now of the 2013 criteria, but we're back again to 5% of the 2021 criteria. So we're still very low as a nation in terms of screening lung cancer compared to other cancer screening programs. So let's step back and look at our program at the University of Rochester. So in 2021, we screened about 4,600 annual lung screening exams. If you look at our greater Rochester area, the population we serve is about 1.1 million patients, including our adjacent 5 counties. And we have about a 50% market share for healthcare. So we screen about 35% of the eligible patients from the old criteria. And we're down to about 20% of the eligible patients with the new 2021 criteria. So we're doing significantly better than the national average. But again, we still have room to go to catch up to other screening programs. So our goals for our lung cancer screening program is to address the population health issues of both tobacco use and lung cancer. And we aim to be the premier lung cancer screening program in New York. We want to do this through 2 methods. We want to improve early diagnosis and outcomes by increasing screening participation up towards those of other mature screening programs, and to prevent lung cancers from developing by fostering a smoking cessation program and resources that are significantly higher than those of other lung screening programs. So how do we try to accomplish this? So first, this has to be a team effort. Radiology and pulmonology were taking the lead in this program for years. But we've now formed a collaborative with Wilmot Cancer Center, with our primary care providers and our thoracic surgeons. So on the physician side, we have a pretty good collaborative that's working together towards addressing lung cancer screening. I still hope to link more with community resources around population health so that we can really integrate into the community's approach to population health with our efforts. We've also put a lot of resources into our program. We built a hybrid lung screening clinic model, and I'll describe to you what that means in a second. So our hybrid model is a change to our current or the standard decentralized model. So typically, a primary care provider or referring specialist will have to determine if a patient meets inclusion criteria, have that shared decision-making visit and bill it, offer smoking cessation services in their office, and place an order, and then manage all the results from lung screening, get the prior authorization, and go through this process every single year. Now, we've created what's called a centralized pathway where we have a lung screening clinic. This is within our pulmonary department, and it is staffed by dedicated providers. And simply placing a referral to the pulmonary clinic is a new way for patients to enter into our lung screening program. So any of our referring providers, specialists, or PCPs can simply make one referral to the lung screening clinic, and our screening clinic will determine if they meet the inclusion criteria. They can perform the shared decision-making visit. They offer smoking cessation counseling and link into the Wilmot Cancer Center, which has an ongoing grant for smoking cessation resources for the entire upstate New York area, as well as placing an order year after year and managing the results related to lung cancer, and eliminating any compliance risk of not performing those shared decision-making visits properly. Our new central pathway also allows for patients to self-refer into the lung cancer screening clinic. So they can simply call the number or below, or send an email or go on the website and enter their information in order to be entered into the lung screening program. They have to have a visit with our lung cancer screening clinic, either in person or through telemedicine, and they can have their examinations ordered at any of the sites throughout our health system. We currently have 6 sites of service throughout our health system, both in Rochester and in all of our affiliated institutions. This allows us to create a dedicated website to encourage patients to learn more about lung screening and to enter the program themselves, even prior, particularly if they have no primary care provider or other resources to assist them in the decision program, in the decision process or obtaining an order, as well as to market directly to patients. And to do that, we created a team. We have a pulmonary APP. We have a dedicated nurse navigator that reaches out to patients and handles these phone calls and emails and helps patients to navigate our system. We have a program administrator overseeing the marketing efforts and other operational efforts around the program. And we have a steering committee with representatives from all of the physician-based groups that I discussed previously. And so our new central pathway is very similar to a mammography model, which is what our referring providers are asking for. So one referral, one time, and the patients can continue to receive their lung screening year after year. We also, in my introduction, you may have heard that I do a lot of work on incidental findings, the most common of which is lung nodules. And in order to get patients with lung nodules, this is another opportunity to identify early stage lung cancer. We've built a system where we keep track of patients, and we know when they've missed visits or they're overdue for either an annual lung screening study or a follow-up visit for an incidental pulmonary nodule. And we have numerous ways to reach out to patients through letters, through patient portal, reaching out to providers through in-basket notices in order to facilitate more communication at the health system level and keep track of these patients that were previously falling through the cracks and coming back in 2 or 3 years with advanced stage cancers. We now keep track of these patients and encourage them to come back. And we've had a lot of success bringing these patients back sooner in identifying earlier cancers in both populations of incidental lung nodules and patients in the lung screening program. So here's a couple shots from our website. So our lung cancer screening, we have lots of information. We have a program overview. We have an easy site, an easy click to make an appointment. We show all of the screening locations that we have running. We have a frequently asked questions section with about 15 commonly asked questions and answers. We have resources to quit smoking and links into the Wilmot Cancer Center Smoking Cessation program, as well as the New York Quits program, and more information for our referring providers. It's as simple, in order to make an appointment, it's as simple as either calling our phone number above, emailing the CT lung screening program, or entering your name into our website, and you'll receive contact within 2 to 3 business days in order to help you set up a visit to get started with lung screening if you're for any patients that you know, or if you're a patient yourself. All right, moving on to goal 2 is the prevention of lung cancers. So every patient that's referred, so we now work closely with the Wilmot Cancer Center Smoking Cessation program. So a lot of their patients that are in there receiving smoking cessation services meet the eligibility criteria for CT lung screening. And so they will send us those patients and we can reach out to them. And they recommend that they participate in lung screening if they're eligible. Conversely, we have a lot of patients in our lung screening program that are still active smokers. And we use this opportunity to encourage them to link up with these smoking cessation services. And I'll explain to you what those services look like. This is well beyond what you get from a standard office-based visit with your primary care provider, who might have 10 or 15 minutes to discuss smoking cessation with you. This is a 60-minute initial phone assessment by a tobacco cessation specialist. Free nicotine therapy mailed to your home. So if you have patients with either issues with cost for these medications or transportation, those are no longer hurdles. Customized text messaging based program designed around an agreed upon target quit date. Their success rates in lung cancer screening are significantly higher than if a patient just reached out to their primary care provider and tried to quit through those resources. And our Wilmot Cancer Institute is dedicated to reducing cancer burden in our entire catchment area, as well as knowing that is going to address one of our region's greatest healthcare disparities with both lung cancer screening and smoking rates. So in October of 2021, just a few months ago, we expanded our service sites into some of the regional hospitals that did not have access to CT lung screening. Both Noyes Hospital and St. James Hospital now have lung cancer screening programs through the University of Rochester. And in approximately March 2022, we will have a Jones Hospital as well as Auburn Hospital going live with lung screening. So increasing access to rural or regional sites of service to reduce that healthcare disparity further and make it easier for patients to enter into lung cancer screening. We're addressing telehealth needs at the same time, so patients don't have to travel in for that initial visit. All right, so one of the take-home messages I have is that by working together, forming a collaborative, it is possible to increase lung cancer screening rates in our community towards that of breast and colon cancer. We are only at 20% right now. That's well above the national average, but there is a lot of room to grow, and we need help from a lot of different people in order to put a dent in the number of eligible patients that come in for screening. Our goal is really to get closer to 50% within 5 years, and that's a very challenging goal. I'm not sure if we'll reach it, but I think we'll get very close to that if we don't reach it, particularly if we can reach out to patients directly. If we can achieve that goal, we will reduce lung cancer mortality significantly in the state, the leading cause of premature death for both men and women in the state, as well as reducing tobacco use rate, the leading cause of preventable death due to modifiable behavior in New York. So what can you do to help? Well, first of all, spread the word. Hopefully I convinced you that lung cancer screening is a population health priority, and that the answer is lung cancer screening, a painless, quick, effective, and essentially free study. The exceptions to this being free is that Medicaid and Medicare, CMS have not yet approved payment for the expanded criteria, the 2021 criteria. If your patients meet the 2013 criteria, they are covered by CMS. So there is an out-of-pocket cost at our institution. It's currently $188 for that exam. Almost all private insurers are covering the lung cancer screening. United Healthcare is the one exception. It's not a common insurance in upstate New York. You can also help us assist eligible screening in eligible screening patient identification. If there's any access to any healthcare data or other outreach programs, and you think you can identify patients and you want to coordinate or collaborate with our program, we would love to have that type of assistance. And we're also looking for ways to increase referrals to the Wilmot Cancer Center smoking cessation specialists for anyone basically in anywhere outside of the city of New York. Here's some interesting facts I want to put before we leave some time for questions or comments. So the initial lung screening exam is about twice as likely as any subsequent study to identify an abnormality regarding follow-up. About 4% of our initial lung screening studies require some additional follow-up. And that tends to be either additional CT imaging at a shorter interval, sort of 3 or 6 months, or a biopsy at the time if the lesion is particularly concerning, or sometimes a PET CT can be helpful if the lesion is large enough, more than about a centimeter and a half and solid. We can help to tell whether that is potentially malignant or not, simply with a PET CT that may eliminate the need for biopsy. Subsequent annual exams, so coming back for that second year, third year study, you're much more likely to identify early stage lung cancer. So unfortunately, some of our initial lung cancer screening studies, asymptomatic patients are coming in still with 3 and 4 centimeter tumors. So we're identifying, middle stage cancers. They're stage 2s, they're even stage 3 sometimes cancers on asymptomatic patients, which is why it's so hard to identify these cancers at an early stage. You really have to bring them in every single year, similar to mammography. We want to look for changes over time. We want to identify these cancers as early and as small as possible to make them as treatable as possible. We want as many patients in that 60% survival rate that we can possibly get. In terms of radiation dose, the amount of radiation administered is very similar to a mammogram, and it's about 1/5 of what a diagnostic chest CT is. So this is very low radiation, and the older you are, the less radiosensitive you are. So the less impact the radiation exposure will have on any chance of you developing a negative outcome from radiation. So again, this is well in line with other standard screening practices. The benefits of smoking cessation for a high-risk individual are roughly equivalent to obtaining annual CT screening. So it's about 50-50 in terms of the benefits. If a patient comes in and quits smoking, even though they have 30, 40, 50 pack year history, that has as big of an impact on their long-term survival in their life expectancy as participating in the program with the opportunity to identify an early cancer diagnosis. So it really is critical that lung screening programs work collaboratively with smoking cessation centers in order to get the maximum benefits for their patients. And one other point is that smoking cigarettes is the only form of tobacco use currently qualifying for lung cancer screening. So there are other forms, vape use, et cetera, that are up and coming, and we need more research before those patients are eligible. A little bit of nuts and bolts here. So shared decision making. Sometimes you get a question about this. What is this required? So this is required for the first visit for a lung screening program. And this is where we document the age, the smoking history, and the fact that they have no active signs or symptoms of cancer. So they're meeting their eligibility criteria, as well as providing counseling around the risks and benefits, including the potential to have a false positive finding. We counsel around the importance of annual follow-up, how finding early cancers is much more likely in year 2, 3, 4, 5. So you don't come in, get one lung cancer screening study, and then never show up again. We really want people participating in this year after year. That's where the biggest benefits are. As well as linking into smoking cessation and having an opportunity to address this, make this a touch point, make this an opportunity where somebody steps back and thinks, yeah, I'm thinking about my risk for lung cancer. I'm thinking about my life expectancy. I'm screening to identify early cancers. This is a great time to potentially intervene and make an opportunity for smoking cessation. And then again, you have to address the willingness to undergo treatment, which can change over time. Getting back to the issue around eligibility for insurance. So for the few patients that are, it is a minority of patients that do not have access to paid coverage of the expanded 2021 U.S. Preventive Services Task Force criteria. Again, this is the patients between 50 and 54 years of age, and the patients who have between 20 and 29 years pack year smoking history. If they have straight Medicare, not Medicare with any additional supplement, or Medicaid insurance or United Healthcare insurance, they currently do have to pay for the service. We offer this at a reduced self-pay rate of $188. This is only at our Rochester site currently. And we can also place patients on a waiting list. We expect that CMS will address this, the payment issue, probably by March or April of next year, although it's hard to anticipate when that's going to happen for sure. All right, so that's the information I wanted to share. I really wanted to answer a few questions and hope people had some questions for us, as well as potentially address some opportunities for collaboration with other leaders in the population health space.
Well, thank you, Dr. Wandtke, for that amazing presentation. It definitely included a lot of information that I was currently unaware of. For all of our participants, at this point, please feel free to go into the Q&A box located at the bottom of your screen and type in any questions that you have that you would like addressed by Dr. Wandtke. Let's see here. And I know that I actually had quite a few. I did have a quick question for you. The screening is annual, but when can someone actually stop the screening process?
Yeah, so as long as you remain an eligible patient, so your age is between 50 and 80, and you've not quit more than 15 years ago, you will continue to do annual screening up until you either age out of the program or you've quit tobacco for more than 15 years. So you would continue from 55, presumably, or 50 or 55 whenever you start until you meet one of those two, until you don't meet one of those two criteria.
Okay, we have a question in our chat box. How is the lung cancer screening program doing in terms of screening Black and Latino patients?
It's an interesting question. It's not one that that I have access to right now. We screen every patient that is eligible. We've not done a deep dive in terms of our health disparities within our own data. Although I believe, as we continue to expand the program, that's certainly an area that we have interest in on a research side. So we are cognizant of the fact that there are disparities. We believe that the 2021 expanded criteria are putting a dent in that, but it will take a conscientious effort to research how important, how big the disparities are in our population, and then to think about ways where we can address those in a way that reduces those as much as possible. So I don't have the answer for you, Francisco.
What happens if you're not eligible, but you start going through the self-referral process? So you go onto your website and you try to make an appointment. What happens if you're not actually eligible for the free screening? Do you not get it? Are you informed right away? How does that work?
Yeah, so we have a couple different ways. So we've got 3 ways patients can enter the program. If they're going into the lung screening program and they've self-referred, our first step is eligibility identification. And that's easy. We have a discussion with them, and we honestly, probably a quarter to a third of the patients that have self-referred have not been eligible, but it still is an opportunity for us to discuss smoking cessation resources with them if they are a smoker, but they just haven't reached 20 pack years. Or to, if they're not the right age, to let them know when they can start, as long as they have that information available. But we are not currently screening patients outside of the eligibility criteria because there simply isn't evidence out there to suggest that is beneficial.
This is a great question. So are there current delays booking out a few weeks or months for getting into screening, especially at affiliate hospitals, especially if you're only at 20% right now of all eligible for our region? What happens if there is a sudden influx of people ready to be screened? Do you have that capacity?
So it's a very rapid test. So at Thompson Hospital, where I'm the chair of radiology, we can squeeze these patients in any day, any time between visits, because it literally is less than 5 minutes on the table. They're in, they're out. So we don't even need a discrete appointment. At most of our sites, we do use appointments for lung screening studies, and we do have some backlogs in CT. There's a lot of this is a certificate of need state, so there's not an excess of imaging CT and MRI machines in the state. We keep them to a limited number, and they're very full fairly regularly. In our regional sites, there's pretty much always capacity to get somebody on the scanner within a couple of days. At our central sites in Rochester, you may have to wait a week or 2 sometimes to get us a routine outpatient CT performed. That's usually not an issue in a screening population. We know these. Our first visit, it's not urgent or emergent to get you on immediately. And our subsequent visits, we can plan ahead. So I don't see that as being a critical issue. We do have multiple sites of service. So if there's a delay that is, at one site, we can route patients to other sites that may not be their closest site, but certainly would be able to get that study done sooner. And I think there's a second question in here. Are we tracking those that reach out for screening and closing the gaps on making sure they come in for screening? Yeah. So as soon as they reach out to us, particularly the lung screening clinic, we have our navigators working with them, and we will reach out to them if they show interest, but then they don't show up. We actually go through our roll of everybody that had a screening study a year ago and didn't come back within 30 days of their due date for their annual screening study, and we reach out to all of them by phone and often by letter as well. The last is that if there's an open order for lung cancer screening, that the referring provider ordered it, maybe it got scheduled, they were a no-show. We also do reach out to patients in those situations. So we do try to close the gaps anytime we have any opportunity or interest. When we've identified a patient that's eligible for screening, because it's so critical to our mission and our goals to get them in, we do anything we can to bring them in.
There's another question in the Q&A box. What resources do you recommend for primary care to speak with their patients to begin this program, and where can those be obtained? That's a great question.
So, I would first go to our website. We've tried to, we've gotten a lot of questions from a lot of people, and we put the frequently asked questions in there. We have resources for providers on the URMC lung screening website. So that's probably the first resource I would use, because we kind of collate that for our local audience. We also have pamphlets and other information that you can have in your office as a primary care provider to share with patients. You can leave them in your waiting room for anybody to kind of glance at or browse at. So you can reach out to Mary Jo who is our project administrator, and I'll put her number in here in the comments so that if you want to reach her directly. But you can certainly call our lung screening phone number at any time and ask for assistance with documentation if you want to have that in your office.
Does your website also list the locations where a patient can go to get the CT screenings?
Yes, so we have sites of service as one of the 5 tabs on the left, and it shows locations of all of our sites within a map. We also do community-wide scheduling for a lot of this. So if you call in for community-wide scheduling, we can often assist helping to find the closest site of service.
So if you have no insurance, can you self-refer? And does the clinic kind of help you if you are eligible for this kind of screening? Does the clinic help you to find somewhere where you can work on getting insurance? Yeah, so we will screen somebody that meets the eligibility criteria that has no insurance. We do have a reduced self-pay option. We've worked with, I shared that $188 rate. That is the lowest I think we can provide within our institution, within our insurance and other legal contracts. So we've got a rate that's that is basically our low self-pay rate. In terms of linking somebody to other community services to try to get them insurance, I'd have to check with the team about whether we do that or whether we refer them to social work or another site that can assist with that. But that's certainly something that's worth considering. I appreciate the thought. Okay. Now this is an out there question. In your "Wouldn't it be great if" listing, you had talked about partnering with community organizations to kind of get this program a little bit more up and running throughout the region. So on your "Wouldn't it be great" list, what are you thinking of in terms of partnering with these organizations?
It sort of depends on what the audience is. In my role as chair of the population health committee at one of our community hospitals, Thompson Hospital, it was clear that there was a shared goals and vision with some of the local community health leaders in Ontario County. They do a lot of health fairs and other ways where they're out there reaching out to patients. They are already talking about breast cancer and colon cancer screening. I'd like to include, I'd like to make sure that our lung cancer screening resources are included in such health fairs and other events. And we're really trying to reach patients any way we can, and having this new way for patients to self-refer, I think, should open up some opportunities for us to integrate better into things like health fairs.
Oh, and thank you, Constance. She did include that you have a pathway for financial services and counseling if a patient has no insurance. That is definitely great information to know. So you had mentioned that there are a couple of holdouts basically for the new eligibility criteria for the USPSTF. So with the 2013 criteria, that is covered then for Medicare and Medicaid. But what if something, so it would be free if you're eligible under the old recommendations, but not yet for anything else. So they still are covered, just not the younger age with a less year smoke history. Is that right?
Yeah. So yep. So those patients 50 to 54 with a 20 to 29 pack year history, if those patients have straight Medicare, Medicaid, or UHC coverage, we can screen you, but there is an out-of-pocket expense. Alternatively, we can put you on a wait list, and we will notify you as soon as coverage is approved, and we can get you in then for no cost or no copay.
Can you briefly just explain what is the 20-year pack year history in case people are not familiar with that?
Okay. So it's a calculation that seems simple at first. If you smoke 1 pack per day for 20 years, that's 20 pack years, and 1 pack a day for 30 years is 30 pack years. But alternatively, you could smoke 2 packs a day for 15 years, would be a 30 pack year history. It gets a little bit tricky when some patients have smoked 2 packs a day for, say, 10 years, and now they cut down and they smoke half a pack a day for the last 10 years. So that's 20 plus 5 is 25 pack years. So that's where the EMRs struggle to make those types of calculations, because everyone's smoking history is not even for the entire time that they've smoked. There's patients that may have quit for 2 or 3 years and then continued smoking later, and so these calculations can be a little bit tricky. But usually we can get them into 1 or 2, 1, 2, or maybe 3 large periods of time where they were smoking relatively consistently for an extended period of time, and just do a simple calculation, addition of those.
Okay. So if you could say anything to those that actually are eligible or know somebody that are eligible for this kind of screening, what would you say to really encourage people to make sure that they come in?
I'm going to go back to the fact that this is basically, this is free to almost everybody. It is painless, it is quick, it is effective, and it really makes a difference in patients' lives. I have diagnosed dozens of early stage cancers since I've started screening this, and every single one of those patients now has an opportunity, a real chance for a cure, a real chance to beat lung cancer, which is very difficult if you have a late stage diagnosis. So think about all the opportunities that does, all the lives that changes and impacts, your ability to see your grandkids grow up, all those other things. This is really, lung cancer affects 1 in 15 men and 1 in 17 women. It is not uncommon. This is a very common cancer, and it is one of the more deadly cancers simply because it presents at a late stage so frequently. We need to change that. So I talked about 75% of patients having either moderate or late stage cancer at diagnosis, and only 25% have early stage cancer diagnosis. When you participate in lung screening programs, those patients, those numbers are flipped. You have 75% chance of getting an early stage lung cancer diagnosis, and only a 25% chance of getting a late stage diagnosis. So it really puts the statistics and the odds in your favor. I understand every patient is unique and every patient's journey is different, but if you're trying to play the odds, you want to be participating in lung cancer screening. It is a very common, very deadly disease that it affects a large number of patients. If you're doing one screening program, you can make the argument that this is the most important cancer screening program that you're doing. Not to say that we should stop doing other screening programs, but if you're going to do only one, this is probably the biggest bang for your buck, and it doesn't hurt. It doesn't, you're not undergoing sedation in a procedure or all those other things that sometimes dissuade people from participating in screening programs. It really is get on the table, get scanned for 30 seconds, get off the table, and we'll see you next year for the vast majority of patients.
That was a very good answer. We have time for maybe 1 or 2 more questions. So quickly, why does it end if you quit smoking for 15 years? So you said that that's when the eligibility ends. So why is that the magic number?
Yeah, so it all goes back to the data from the trial. So, these screening programs, particularly as risk-based, really it falls back to the data. So when you dig deeply into the National Lung Screening Trial data, they looked at over 55,000 patients for a period of about a decade. And they tried to monitor, who was getting lung cancers and when, and what were the risk factors for those patients. When you went beyond 15 pack, when you would quit for more than 15 years, your risk of developing a new lung cancer was really almost equal to those patients who had never smoked. So, if you're going to get cancer related to your smoking, it happens while you're smoking or within 15 years. That doesn't mean that patients who don't smoke never get lung cancer. Believe it or not, there's actually a reasonable number of patients who do get lung cancer who've never smoked. It's just that, if you smoke, your risks are 2, 3, 4, 5 times as high. And so those are where we're putting our screening dollars and our screening efforts right now.
What that sounds like to me is that there really is hope for people that have smoked or have smoked for a long period of time, that really, if you quit, you have the chance to then revert back to having the same risk as those that never smoked.
Yeah, I mean, if you're 50, 55, 60, and you quit smoking, the chance, by the time you reach 50, 55, 60, the chances of you living more than 15 years are pretty good. So, we encourage everyone to stop smoking, even up towards the end of the program cycle, because as people live longer, you're going to have more opportunity to benefit from smoking cessation. And again, smoking cessation is not just lung cancer risk, it's also heart disease, hypertension, strokes. There's so many things linked to so many poor outcomes linked to tobacco use that it's a very important part of the lung screening process.
Well, we're nearing 1 o'clock. So I would like to say a very sincere thank you to Dr. Wandtke for coming in today and talking about this program. I will make sure that when I send out the recording of this event, the link to the recording, along with the survey follow-up, please fill out the survey. I will also send a link to the website and the phone number listed. So if anyone has any additional questions, wants to send any information out to the organizations or communities that they work with, please feel free to do so. If you have any questions in the meantime, please make sure to email me and I will forward them on as appropriate. So thank you everyone for joining us today for our community conversation on cancer. I hope everyone has a lovely end of the year, and we will see you again in January with our next community conversations. Have a good afternoon, everyone.
Thank you everyone for your time and attention.